You're listening to the Autism Weekly podcast. Each week, we share community voices and bring light to stories that increase awareness, acceptance, equity, access, and inclusion. If you haven't already, subscribe to join the Autism Weekly family. I'm your host, Jeff Skibitsky. This week, we're joined by Dr. Lauren Moskowitz, a clinical psychologist and researcher at St. John's University, who studies something so many families know firsthand, the intersection of autism and anxiety. For many autistic children and teens, anxiety isn't just a side challenge. It can be one of the biggest barriers to daily life, school, friendships, and feeling like they belong. Dr. Moskowitz and her team have developed a therapy program specifically designed to treat anxiety and other mental health challenges in autistic individuals. Today, we're getting into what that looks like and what families can do right now. Dr. Moskowitz, welcome to the podcast.
Hi, thanks for having me.
It's a pleasure. And I know that when you and I have chatted, it's the idea of anxiety and autism. These aren't two topics that don't cross paths often. It should be something that's right in the forefront of our brain constantly. But it isn't. And unfortunately, providers are oftentimes isolated when they're treating these two particular conditions.
Absolutely.
But before we go there, I'd love to hear your background. I'd love to kind of know what drove somebody's interest, especially because not many people have blended these two conditions as far as their research.
Yeah, no, absolutely. Well, I got into working with kids with autism over 26 years ago. Just because I think, I loved how they looked at the world differently. I loved how, I don't know, the kids I worked with appreciated things in a way other kids around me didn't. They would feel the wind, they would notice lights and sounds and details and things no one else noticed. So I just, thought they were really fun and enjoyable to hang out with. And I just, fell in love with that population. In terms of the anxiety piece, like I said, I got my start right out of college, an ABA. I think like a lot of people do sometimes right out of college. And for those of you who know, they in ABA, they say there's these 4 functions of behavior, and at the time, the term that we heard a lot was escape demand. Kids are engaging in challenging behaviors like aggression, self-injury to escape demands. And a lot of the kids I worked with just seemed so anxious and afraid. And there was no mention of that at the time. And I remember saying to my late advisor, Ted Carr, when I started grad school, is it really all escape demand? Isn't a lot of their behavior just to escape anxiety? And he was saying, yeah, but behavior analysts don't use that term, anxiety, because that's mentalizing, and we like to stick to things we can see. And, the way we measure anxiety as clinical psychologists, school psychologists, we measure anxiety typically by asking people, how do you feel? Are you afraid? Are you anxious? So when people have a communication difficulty, as folks on the spectrum often do, a third or non-speaking, and even those who are fairly verbally fluent sometimes have difficulty expressing their thoughts and feelings and emotions, especially when dysregulated. So it's really hard to assess anxiety in this population. So it was often really overlooked. So that's what really drove me to really be interested in anxiety in this population, that it just seemed like it was such a major issue in all the kids I worked with, and no one was talking about it or calling it anxiety. You couldn't call it anxiety, and no one was really trying to treat it at the time. This was, 20 years ago. Now, a lot of people like Susan White and Jackie Rogers and really Jeff Wood, a lot of wonderful people, Judy Raven out there have really been, developing CBT programs to treat anxiety in this population. But when I started grad school a very long time ago, that wasn't the case. So
no, absolutely. And I think that what you're describing is something that the idea of holistic care, or really understanding the interpersonal kind of interactions, also the internal events, like how is somebody feeling? How are they processing something? Like how are they viewing the situation? What's emotive about it? Those seem like very important questions to be asking throughout all of treatment. What does that look like right now, as far as if you were to take ABA and you were to take cognitive behavioral therapy, where do you see the intersection of, this
Yeah.
is kind of maybe where these things should be looked at as far as,
Yeah.
the clinician viewpoint.
Yeah, that's such a good question. I don't see them as incompatible. I know some people do. I see everything through a pretty behavior analytic lens at the end of the day. So I think for me it's not incompatible. I think I've definitely heard BCBAs, behavior analysts say to me, there's no such thing as anxiety. I've had that said to me a bunch. Um, I don't believe that. Skinner himself said there were private events, and that they weren't really any different. They didn't operate any differently than publicly observable events. And I think that that's true, So I don't think anxiety is something fundamentally different. I think it is hard to assess. It's hard to see sometimes. And, you know, I do tell my students sometimes not to jump to conclusions and call everything anxiety. Often, sometimes my students will say, oh, the kid's doing this because they're anxious or they're frustrated or they're angry. If we don't have evidence of that, I think we don't want to jump to conclusions about what people might be thinking or feeling. But I think it's important to be able to operationally define these things, to try to say, what does anxiety look like? And that can be really hard, especially in kids who are non-speaking. But that's what, I'll try to do with the parents or teachers I work with, to say, okay, how do you know when they are afraid or anxious versus when they just like don't like something? Like if you're like, eat broccoli, and they're like, no, I don't want to eat broccoli. And usually when parents and teachers look closely, they are able to figure out the signs. They're able to identify, okay, when you say eat broccoli and they don't want to eat broccoli, they'll yell no. But when they're afraid or anxious, they might rock or they might
Hmm.
hum or they might also say no, but there's these other things accompanying it. It might be accompanied by crying or whining or freezing or singing or there's a change in the frequency of something. Like a kid might rock all the time, but then when they're anxious, the frequency of their rocking might get faster or more
Yeah,
vigorous, right? So you see these changes that parents, once they really start looking at it, and teachers are able to say, oh, yeah, that's what they do when they're anxious. For some kids, it could be a specific throat noise. Like one of the kids, he would go like this kind of noise in his throat when he was anxious. But when you start really observing, you can see that that they're anxious, that they're afraid, I think, but historically that has definitely been overlooked. So I do think it's
absolutely.
important to be careful when we're ascribing emotional states to people, that we're not, misattributing what they're thinking
Mhm.
or feeling sometimes, but to really try to figure out, how are we gonna measure these constructs? How are we gonna assess these things that are very real emotional states? Because yes, as a behavior analyst said to me once, it's all escape demand behavior. I don't think that's true. I think there's a difference between when you're escaping or avoiding something you just don't like, versus something that makes you anxious. There's some similarities in how we would treat it, and then there's some differences too. And I guess that's the
Mhm.
integration, of ABA and CBT. I think if you're afraid of something, you would want to integrate what we would call cognitive restructuring, or really trying to help people think about it differently, or come up with coping statements like, I can do this, I can be brave, or perhaps relaxation might play a role. But the biggest thing would be exposure. If there's something you're
Mhm.
afraid of, the main CBT treatment for that is gradual exposure, so really trying to help people to face their fears. So that, might be a bit different than if it's just a situation someone doesn't like, a
Yeah, the
task
way
that they don't
that
want to do, like brush their teeth.
Yeah, the way that you're conceptualizing this right now, I
Yeah.
mean, it hits with everything that you'd be looking
Yeah.
at for compassionate care, for giving somebody agency back, for being
Yeah.
able to empower somebody. If you're marginalizing that and not putting it as part of the thought process of being able to really do a case conceptualization, really understanding somebody, then you're missing
Mhm.
a key piece. But how often is this? I mean, is
Yeah.
anxiety very common with the autism
Yes.
community?
Yes, very. It's the most common mental health problem that we have. I mean, it was really, like I said, historically underdiagnosed. But
Hmm.
Connor Kearns, a colleague of mine who's done some amazing research, in one of her 2021 studies, they found 69% of kids with autism had clinically significant anxiety, like met criteria for at least one anxiety disorder. That's really a lot. That is so much higher than
Hmm.
the general population. And in adults, I think there was a study, I want to say maybe Holix in 2019, where they found about 42% of adults had a lifetime prevalence, of anxiety, had anxiety disorder at some point in their life. So really, really much higher than the general population. And even that might be an underestimate,
Mhm.
because there's so many cases that are probably missed where people can't really articulate it or say it, or the behavioral indicators are really unique or idiosyncratic and we might not ever recognize it. So even that is probably an underestimate. But yes, it's extremely common, the most common mental health problem we have in this population.
Yeah, and I mean, when I'm looking at the research that's come out over the last probably 10, 15 years, is that a lot of it's focused on the adult autistic population and
Mhm.
anxiety and depression, where
Yeah,
maybe the skill set is there to be able to express it in
yeah,
a way
yeah,
that it makes it easier to diagnose.
yeah,
But I mean, when you're looking at an autistic child, is that you're not always going to see, or it's not going to present always in the same way. It's not going to be, well, I can express
yeah,
my worriness or my nervousness to you. What
yeah,
does that look
yeah,
like? What does that feel like for a
yeah.
younger child?
Yeah, I mean, I think, again, Connor Kearns has done some great research on the atypical presentation. I think about half the time they can have the same kids on the spectrum can have the same fears and anxieties the rest of us have, generalized anxiety or separation anxiety or social anxiety. But the other half the time, it's what we would call these kind of more atypical anxieties, right? Like very kind of idiosyncratic phobias, like maybe instead of just a fear of spiders, like a fear of like a specific mechanical noise, like a hand dryer or a vacuum, or one of my kids had a fear of left and right turns. That's what I mean. Like stuff that you don't really, maybe to just be very unique to that one kid. It can be anxiety surrounding transitions, which is really common in kids with autism, which you don't really see in neurotypical people as much, in the diagnostic statistical manual, that's not its own category. But this anxiety around changes in routine, novelty, transitions is extremely common in kids on the spectrum. Fear or anxiety around when they can't engage in their special interests is also really
Mhm.
common. But what does it look like? I think the hard part is it can so often also overlap with core autistic traits, right? Which is why it's also so hard to diagnose. Because, if you see someone socially avoiding, social interaction, for example, is that the kind of social avoidance that's characteristic of autism, or is that social anxiety? Or if you see repetitive behaviors, is that the kind of repetitive behaviors that are characteristic of autism? Or is it the repetitive behavior you'd see in OCD, for example? Right? Does that make sense? Or when
Absolutely.
you see a kid asking a repetitive question over and over again, which a lot of kids with autism do. That's something that you see a lot in autism. It could be because they like asking that question over and over again and getting the same response. Or it could be indicative of OCD, where they are engaging in the ritual for reassurance to make their anxiety feel better. The
Mhm.
key is determining what the function or purpose of it is when you're determining if it's anxiety or autism. But again, that's easier said than done. It's not always easy to do that when communication is not always, you know, what can be difficult for this population. So it can look like a lot like autistic traits sometimes, and that's where it can also be a bit hard to discriminate.
Mhm.
For non-speaking kids, like I said, I will have parents identify what are the specific behaviors. Is it freezing? Is it clinging? Is it rocking? Is it humming? Uh, there's usually very specific things the kids do that are maybe unique to them that can indicate it's anxiety, which then makes it hard to use any of these standardized measures we have because it can be very unique to the kids sometimes. My child who was afraid of left and right turns, for example, he would yell no, he would scream no left, no right, go straight. But also he had a fearful facial expression, his eyebrows were downturned. And when they would make a left or right turn, his family, he would look out the window like this and watch the left and right turn. So all of that was, what we counted when we were coding at the time as anxious behaviors.
Mhm.
So it's kind of unique to a lot of the kids. But then sometimes it can look very typical, like it looks in neurotypical people, it can just look like crying or running away or freezing or clinging, it can look very typical. But it has to be in context. You have to look at these behaviors in context because if a kid's crying, you can't just say, oh, they're anxious. right? You can cry because you're sick. You can cry because you're in pain. You can cry
Hmm.
because you're frustrated. You can cry because you're bored. You can cry for a whole lot of reasons. So it may not be anxiety. So
Yeah.
it's not that any one behavior on its own indicates anxiety. It's which is what makes it challenging. It's looking at it in context and, looking at the whole package. Are they crying and running away and yelling no? And is that something they do when you give them something that how do they behave in other situations? Like I said, like when you're just giving them something they dislike or a task that's too difficult, perhaps.
Hmm.
So a lot of it is that kind of comparison. And so, like I said, I think for kids who are fully verbally fluent, there's some parent report and self-report measures we can use that are pretty good. Like Jackie Rogers has a measure that's for free on her website at Newcastle that is called the ASD, I think, and it's a anxiety self-report measure for kids and parent report measure. But all of that stuff is only for kids with like an IQ above maybe 80, who are verbally fluent. The population that's most neglected, you were talking before about kids being neglected relative to adults. There's a fair bit of research at this point that CBT is effective for autistic youth,
Hmm.
but none of them have an intellectual disability. That's where the real gap is. The kids who are non-speaking or have an intellectual disability, they're not really represented in any of the clinical trials. All the clinical trials to date have an IQ cutoff below 80 or 75. So
Yeah. And the
yeah.
identification is hard, but I mean, when you're talking about treatment right now, it's a coordinated care, collaboration of care. That is such a core piece of providing appropriate treatment and being able to
Yes.
empower somebody through it. But I find
Yeah.
is that with anxiety, especially as we're talking with psychotherapy to behavior analytic approaches, it's oftentimes I feel like the family's getting punted back and
Yes.
forth because of the
We're
two
so
sciences not
right.
always aligning.
Yes.
So is that
Yes.
is that something that maybe it's because we're not speaking the same language
Yes, we are
clinically
not.
and
We are not.
meeting the need. Is that something that's being addressed right now? Is that something that that there are
I
programs out there
mean,
focusing on?
yeah, I mean, many people are trying to. My colleagues and I, Matt Lerner at Drexel and Dina Gassner and Rebecca Sachs and Alison Namias, a bunch of us, we developed a program called Spirit IDA, and it's being run mostly out of Drexel. And it's really designed to try to bridge that gap because, often autistic folks are really siloed. They're really sent back and bounce back and forth, like you said, between they're often treated by BCBAs or speech pathologists or, who don't maybe know how to treat anxiety. So they'll say, okay, go see a mental health professional, go see a psychologist or social worker, mental health counselor. But then they go to them and they say, oh, we don't treat autism.
Hmm.
Most clinics, I mean, the research shows most clinicians turn away autistic clients, even for problems they say they treat, like anxiety or depression or whatever else. For some reason, they just don't feel equipped to treat this population. I've seen even at the training clinics that at the universities I've been at, they will say we treat anxiety, we treat every population, but no, 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 we don't see kids with autism. Why is that? I'm not sure, because it really isn't that different in how you treat it. There's some modifications, which we can talk about, but there's more similarities than there are differences. So
Yeah.
it has always really confused me. I think sometimes mental health professionals are intimidated by the challenging behaviors, the co-occurring challenging behaviors, the aggression or the self-injury or the tantrums, I think sometimes can feel intimidating. I've also heard some of my new students, or my new trainees who maybe haven't worked with kids with autism yet, they'll often say, I'm trying to get through this CBT manual to treat anxiety, but they keep talking about this one thing the whole time, so I can't get through it. I hear that a lot.
Hmm.
So those are things we have to address and saying, okay, instead of trying to fight the focused interests or the intense interests, let's figure out how we can incorporate into treatment and leverage that. So I think there are some things that it helps to have some of that autism awareness and know about, but that's not so far that hasn't been happening. There's just been a huge divide between the mental health field, as evidenced by, in New York State, we have, OMH, Office of Mental Health, and then we have OPWDD. They are separate branches, that do
Hmm.
not interact. So a lot of us are really trying to fix that. So the program my colleagues and I have developed, Spirit, is really trying to train mental health practitioners, mental health providers in New York State, and we're opening up to other states too, where we're trying to train them to feel comfortable, feel more confident and competent to provide CBT and therapy in general to autistic youth and adults, and youth with
Hmm.
ID and adults with ID, intellectual disabilities. So that's what we've been working on. And there's that eagerness there. People want to learn. They want to be able to feel like they can work with this population. They just don't feel confident in doing so. They don't feel like they have the tools to do so.
Yeah,
So
and
that's what
that
we're
same
trying to do.
phenomenon, I mean, it happened in the pediatric world not too long ago, where pediatricians
Totally.
were saying, I'm not fully equipped, and it almost was everybody had to go to a specialist. But when you gave
Yes.
the tools, the
Yes.
pediatrician felt more
Yeah.
comfortable, more confident, and understand how to be able to process through their visits and really get to the root of problems. Is that, I mean, when you're going through this and you go through the
Yeah.
trainings and you're starting
Yeah.
to empower clinicians,
Yeah.
what are the skill sets that they're saying they're missing? What is it that's just either on one end or the
Yeah.
other? Like what's the gap?
That is so great you asked that, Allison. Dr. Allison Ami has actually just developed a survey, one of my colleagues, and we're all kind of working on it, where she's actually surveying practitioners to find exactly that. But I think what we're hearing a lot is, most of them don't know how to deal with either the behavioral challenges, that's what seems to come up a lot, and how to deal with the intense interests. I think that comes up a
Hmm.
lot. But one of the first things we teach, I think, when we're doing it is just in general a more neuroaffirming approach. I think a lot of the providers have never heard, for example, about like the double empathy problem. They've never heard that, folks on the spectrum sometimes don't have difficulty communicating with other autistic individuals, and that the empathy divide can go both ways. Often neurotypical people don't necessarily understand the communication cues and expressions of, folks on the spectrum, just like vice versa. Yet the burden is always on autistic people to try to conform to neurotypical standards. And so I
Hmm.
think a lot of the time mental health professionals have just not heard that perspective. And it's a it one of the first things we just try to discuss is what is your goal and why? And that the goal shouldn't just necessarily be to appear neurotypical, but the goal should be to improve people's quality of life. And what does that look like and how are we going to do that? So that that is a lot of, I think, what we discuss in terms of just, and then also just the ways in which CBT is modified for this population, the things that stay the same, but then the things that we do differently,
Hmm.
is a big piece of what we discuss. Like, for example, more parental involvement
Yeah.
to facilitate generalization. When you're treating anxiety in neurotypical children, there's not a whole lot of parental involvement all the time, like something like Coping Cat, which is a manualized treatment for neurotypical youth to treat their anxiety. There's pretty little parent involvement. There's like a brief check-in with parents every maybe 4 or 5 sessions. For autistic youth, you need really a lot of parent and teacher involvement to facilitate that generalization. It's not like one 45-minute session per
Hmm.
week is going to do much. You need people and natural intervention agents in their lives who are really helping to coach them through their anxiety and facilitate this. So there's really a lot of parent training and sometimes teacher training too. Either parents are involved in all the sessions, or in the case of like a group intervention, like Judy Raven or Audrey Blakely Smith's Facing Your Fears approach. There at the University of Colorado, they have a wonderful group treatment for anxiety in autistic youth. They have a separate group that's running for the parents the whole time, where the parents are learning the skills they need.
Yeah.
So there's really a lot more parent involvement. That is one of the modifications, but there's several. I'm just, giving an example. I can talk more about
Hmm.
this, but yeah, these are the things we're trying to teach.
But that's a commonality, I think, with a lot of practices that work
Mm,
with individuals who identify autistic, is that you create
mm,
a community support network, whatever that may be,
yes,
to be able to be
yes,
involved with helping to navigate difficult situations, being able to
yeah,
identify or support on barriers, being able to help build
yes,
skills where that person wants to build skills, all about the
exactly.
empowerment and self-determination. But I mean,
Absolutely.
so
You're
parents are
so right.
walking into this in such a
Yeah.
challenging space. I mean, it sounds like you're educating a
Yeah.
lot of the providers and that you're helping them as well to be able to educate the families to give them a
Yeah.
role and to give them a functional way to be able to engage in the process. But
Yes.
families don't have this map to begin with.
No,
So, I mean, if you see a
no.
family and and you were to talk with them and they say, hey, my child every morning when they're running into specific things is that they're quote unquote melting down, like they're
Yeah,
falling apart and I
yeah,
don't know what to do. I get, and a
yeah,
lot of times is that it's like, well, as a parent, you're like, well, I'm going to force them or I'm going to help them get there or whatever it is, instead of thinking through all the process of how is that child internalizing what's occurring? What are the skills that's going?
yeah.
I mean, it's so much to do. But what do
It
you
is a lot
suggest
for
for
parents.
families as they're seeing that at first? Like, I mean, is it create
Yeah.
that community, create the outreach? I mean, what's there?
Yeah. I work a lot with parents. That's my main area of interest, honestly, is working with parents. Since I became a parent myself, even more. I have a 12-year-old and a 7-year-old, and it has really humbled me drastically, I will say. I look at all the behavior plans and the things I came up with before, and now I'm like, like I thought parents could do all that. That's funny. Now I have a much better sense of what is realistic in parents' life. And I see how, I remember before I had kids, a parent came to me with a 10-year-old who was afraid of all creamy things. And the kid had never brushed their teeth with toothpaste, had never, used shampoo or conditioner, nothing creamy. And I remember thinking, wow, how do you get to 10 like that? Now I get it.
Hmm.
Because as a parent, the time passes so fast, you're just trying to survive. And you're like, the kid's melting down. You're like, I can't deal with this today. Fine, they can just brush their teeth with water and no toothpaste. I'll deal with this tomorrow, and tomorrow becomes tomorrow becomes tomorrow becomes 10 years. I see now how it happens
Yep.
because you are so just trying to survive and get through the day. And
Hmm.
I never fully understood that before. So now my empathy for parents is extreme. And, when I see there's so many treatments out there, for example, I don't know if you've heard of the space treatment at all, which is a treatment that's just for parents of kids with anxiety. There's only been one study where they've examined this in kids with autism, but it's mostly for parents and neurotypical kids with anxiety, where they're
Hmm.
just working with the parents on not accommodating the kids' anxiety and being validating and supporting. And it makes sense from a evidence-based perspective, from an intuitive perspective. Obviously, if you're accommodating a child's anxiety, answering questions for them instead of having them answer it, leaving the house if there's a dog they're scared of, letting them stay home from school when they don't want to go to school, letting them sleep in bed with you if there's, all of those are examples of accommodations where you are
Hmm.
reinforcing their anxiety, where you are giving in to them. You are sending the message then, I don't believe you can handle this on your own. I'm going to do this for you, right?
Yep.
Which just in the long run maintains anxiety. I understand all that clinically. And now as a parent, I get how to just tell parents, hey, you can't accommodate anxiety can feel overwhelming because especially
Hmm.
parents of kids with autism, they are accommodating all day long.
Yep.
I've met kids where they say to the parents, you can't speak in this language. Or a parent once came into my office and sat like this, and the kid said, you can't sit like that. And the parent was like, oh, I'm sorry. So parents are stepping on eggshells all day long sometimes to accommodate their children, their kids' anxiety, or not even anxiety. Sometimes it's not even anxiety. It's just a preference for sameness, wanting things to be a certain way.
Hmm.
And parents are, like I said, all day long, they're accommodating this stuff. So what I try to tell parents is like, you're going to go nuts if you try to just say, okay, I'm not accommodating anymore. So we'll just focus on just one little thing
Yeah.
that we're going to choose to work on or not accommodate. And the rest of the stuff, we'll let it slide. We're just
Hmm.
going to let it go now. We can't fight every battle because as a parent of a kid with autism, like your life is so much harder and
Yeah.
we can't fight every battle. So I tell them we're just going to, like my older daughter, yeah, I remember she went through a period of only wearing a leopard print in her school uniform school in elementary school. And I remember the principal called me about the uniform and I said, if this is what you want me to target, I will target this. But, personally, I don't think this is our biggest fish to fry. And she's like, all right, we'll let it go. And I think
Hmm.
that's kind of what I advocate with a lot of families. Like, if this isn't your biggest issue, we'll just put this to the side for now and we'll work on what is the issue that is most impairing your quality of life. Because if you just try to say, I'm no longer going to accommodate all of these things, it's going to be very overwhelming for you. And you're going to
Yeah.
have a huge extinction burst, and parents can't deal with that, is the
Yep.
reality, right?
And that would be like, I mean, that would be
Yeah.
for a neurotypical child or a
Oh,
neurodiverse child. There's
any
so many
kid, but
commonalities,
yeah.
I feel like.
Yes, yeah, yeah.
Where's the treatment different, or is it just that you're applying things to a different level of scrutiny? I mean, is it, or
Yeah.
where
I
is that?
I can definitely answer that. Yeah. So there's a few, the similarities, of course, are you're still doing, when you're treating anxiety, the core ingredient, whether it's in a typical kid or an autistic child or an adult, is the main ingredient is gradual exposure. That's the main thing you're
Hmm.
doing, facing your fears. You're also doing cognitive restructuring, trying to help the kids think about their anxiety differently. Like, what's the worst thing that's going to happen, and how can I cope with that, You're trying to help them come up with coping statements like, I can do this, or I can be brave. I've done this before. I can do this again. In some cases, you might be teaching them relaxation exercises. Sometimes that's not always indicated. Those are some of the main commonalities. We also tend to do psychoeducation. That's a commonality where we're trying to explain to them that anxiety might feel uncomfortable, but it's just a harmless emotion.
Hmm.
It's just like a fire alarm goes off in the house. Your body has this fire alarm, this fear alarm that's going off when you think there's danger. And you're evolutionarily designed to have that. You want to run from a lion. You want to be motivated to study for a test. Anxiety motivates us to action. So we want to have it. But in your case, it's like a toaster that's going off when a fire alarm that's going off when there's just burnt toast instead of an
Hmm.
actual fire. Your fire alarm's a little bit sensitive. So we will explain it to kids like that. So when they're having anxiety, anxious thoughts, and fearful thoughts, we'll teach them to say things sometimes like, send back the fire trucks. There's no actual fire. That's just my worry. That's just my anxiety. I don't have to listen to it. I don't have to pay attention to that. So we do a lot of that. All of that is the same. What's different is, like I said, more parent involvement and teacher involvement. That's one of the big things. The other thing that's different is we have to make it a lot more concrete and visual. Kids with autism do very well with visual supports, obviously. And so that is something that we need to do a lot more of. I will write social stories for them to convey a lot of the psychoed or to explain the cognitive restructuring or to explain the process of exposure. Um, so all of this stuff is much easier. If you're just explaining it verbally, it's going to be really challenging to explain. So I explain it all very visually, just like we would for anything else, a lot of social stories, a lot of comic strip conversations, a lot of double bubbles where I'll draw, their favorite, we'll have a picture of their favorite character who looks anxious and then not anxious. And we'll put the anxious thoughts on one side in the thought bubble, where all the anxious thoughts, and we'll write them down together, and then all the non-anxious thoughts on the other side. So it's just
Hmm.
ways of making it very, very, very concrete and visual. That's the biggest modification. All of that can be helpful to neurotypical kids too, honestly. I think just it's not what's typically done. So there's a lot more lists, like on, for example, one of a child I worked with a long time ago who had OCD, um, and autism. He had a lot of health anxiety, so he would always ask his mom, am I sick? Am I healthy? If someone coughed, do you think I'm going to catch a cold from them? Do you think I might die? Does my face look right to you? Am I breathing right? Do you think my heart sounds okay? A list of questions, about 50 questions a day, right? And
Hmm.
mom, very, what do you think mom did? Answered him each time. Of course you're not sick. No, your face isn't red. Yes, you're breathing right, right? Like any parent would, because you want to make your kid feel better. You want to reassure them, right?
Yeah.
Of course, that's just maintaining the anxiety, though, right? So
Hmm.
we wrote a social story for him. I wrote a social story for him where I explained, when I put a little bubble in there, it was his picture and like a call out saying like, Mom, am I going to get sick? And that was crossed out. And he was like, oh, I always ask Mom, am I going to get sick? I'm like, right, the story's about you. He's like, how come it's crossed out? I'm like, because we're not going to ask that anymore, right? When
Hmm.
you ask that, you're making the Undertaker stronger, who is what we called his anxiety, the Undertaker, because he liked WWF. So we were able to explain, this is not something you will ask. And from now on, when you ask mom isn't going to say anymore, yes, you're healthy, or no, you're not sick. And then that was crossed out, her saying that picture.
Hmm.
So it was a way to help him understand what was going to happen. Of course, we also had like a reward chart where he would get stickers for every half hour he could go without asking those questions. But we made it very visual where we would put on one side of the sign, okay, here's all the anxious questions that are crossed out. These are all the things you shouldn't ask. And here's all the things you can do instead, right? So it was a way of making it very concrete and visual. and incorporating his mother so that she wasn't just ignoring him if he asked that question. But if he asked, am I sick? She would say, oh, that's an Undertaker question. What should we do? So do you think I should answer that? Is that going to make the anxiety stronger? So let's go do something else instead. Let's go play a game, right? So she wasn't, she was aligning with him against his anxiety then,
Yeah.
instead of just like, I'm not going to ignore you, or I'm going to ignore you, which of course doesn't feel good to parents, right?
Mm-hmm.
So I think the biggest modifications, like I was saying, are, incorporating the parents, really trying to make it a lot more concrete and visual. Treatment can take longer. It can take a lot more sessions. You have to probably move at a slower pace and allow for a lot more repetition. And also the other biggest thing is incorporating special interests. That is also, it helps even with neurotypical kids if you incorporate things they're interested in, but with kids with autism, it is essential. They
Mm-hmm.
often do have a focused interest or intense interests. And like I said, I think a therapist who's not experienced with that population will try to say, let's stop talking about that because it can be excessive.
Yeah.
Um, but I will say, instead of not talking about it, let's figure out how we can incorporate that into treatment. So if a kid
Mm-hmm.
has a special interest in Harry Potter, explaining it to them in terms of Harry Potter, and you're conjuring a Patronus charm to fight your anxiety. So it helps them not only buy in and motivation, but it helps with the comprehension. It helps them understand why they need to fight their anxiety, or what they need to do, or what you're asking them to do, if you can
Mm-hmm.
put it in terms of their special interests,
Yeah.
which um, is the main approach that I would say has been the most useful with this population, really trying to capitalize on their interests in
Mm-hmm.
stories, in the psychoed, and the cognitive restructuring, and in the exposure itself, trying to figure out how we can incorporate that into the exposure itself.
I mean, it sounds like there's a lot that's going on conceptually. There's a lot that's going on
Yeah,
techniques. There's a
yeah,
lot that's going on in being able to create a role for so many different people. But consistency is kind of the
yeah,
one of the core components, is that you need everybody being able to respond in a very similar
yeah,
way.
yeah,
Most
yeah.
kids are in school for a majority of their days. So, I mean, what's the role
Yes.
for schools in this
Yeah.
process?
That is such a good question. I think it really depends, because there's some kids who they have anxiety across the board at school and at home, right? And then they really need to be on the same page. There's some kids, though, who, I'm sure you've seen this, the school may not know about it. They can really hide it at school. They might spend all day really trying to hold it together and not let the teacher know they have OCD and that they're so scared of germs all day. And then they let it all hang out when they come home. They're just like rapid fire questions at the parents. So there's some kids who can really hide it at school, and it's not as much of an issue at school, more at home. And vice versa, there's some kids who don't have really much anxiety at home, and most of their anxiety is at school, either related to um, test taking anxiety, for example, or public speaking, maybe standing up in front of the class and speaking, or just like talking to other kids, or talking to the teachers, or to assignments, or for some kids with OCD, their contamination OCD is way worse at school than at home, because everything at at home is like safe, but then everything at school can feel contaminated. So there's a lot, some kids, their anxiety is only present at home but not at school, and then other kids it's vice versa. Their anxiety all comes out at school and there's really none at home. So I think it
Mhm.
really depends. If it's only in one place, you really just need to kind of target it in that one place. But the times when there's a lot of carryovers, where we really need to involve both parents and teachers. I don't know if
Mhm.
that answers your question, but
No,
yeah, a
it
lot of
does. And it
times some
sounds like
places
the
can
the
be okay.
same training would almost trickle
Yeah,
down as that, whether it's home, school. I mean, to make it
yeah,
environmentally agnostic and to allow that child to have a safe
yeah,
place instead of being managed in any given
yes,
environment. So, how
yeah,
important is
yeah,
that to make it so that the child actually has that feeling of, I'm safe. I have the skills. I know what to do, versus feeling like
yeah,
somebody is going to take care of this for me, or somebody is going
yeah.
to
That is
modify things.
such a good point. I'm glad you asked that. I think the main thing that we try to instill is a sense of coping and self-efficacy, right? So, I think a lot of the times people think exposure means we're forcing a kid to do something. That should never be the case. And to be clear, there are some old school studies, the 50s, 60s, 70s. I'm thinking of a study where a kid with autism was afraid of pools. They didn't call it afraid, they called it pool avoidance. And they basically did response blocking and forced the kid to not, be close to the pool and not run away from the pool. That is not something I would ever do, or advocate for. I think kids with autism and adults on the spectrum, they have a history of being given less control and less autonomy over their lives. And that just breeds anxiety when you feel a lack of a sense of control over your life. I tell my college students all the time. I always ask them, were you happier in college or in high school? And almost all of them say college. And why? Because they have more choice and control over their lives. My kids, when they come with me to college and they see my students just get up and leave class, they say they can just leave class whenever they want. They don't need to ask your permission, Um, that is that is such a big deal in life that I think we as adults forget what it's like as kids in general not to have that kind of control over your life. But as bad as that is for a neurotypical kid, for kids with autism, they get even less control.
Mm-hmm.
And many of the kids, when I first talk to parents and I explain what exposure is, they say, oh no, we're not going to do that. Like a family called last year whose kid was afraid of water. Like
Yep.
their kid with autism was afraid of water. And they said, no, we're not going to do exposures because he had a really bad experience with that. His teachers in school threw water on him to help him face his fears, and it made it worse. We are not talking about throwing water on somebody, right? We're not
Mm-hmm.
talking about forcing or coercing somebody to face their fears. Of course, that's going to be traumatizing when you have experiences with people who force you to do things. That
Mm-hmm.
doesn't feel good. I mean, most of these kids have been held down at the doctor's and dentist's office, which is terrifying, right? We don't ever want to hold kids down. We don't ever want to force them to do things. The
Mm-hmm.
key is motivating them to want to face their fears. And you can do that if you find the thing that motivates them. You can
Mm-hmm.
motivate them. You can, right? And you can, with kids who are afraid of the doctor. A good example I always use, we had a kid with autism who, he was held down at the doctor's office by, because he had to go every week to get blood tests for his seizures. And instead, we said, okay, what was his favorite thing? And mom was able to isolate that he loved Potato Head and he hadn't been they'd taken it away a few years ago because he was so obsessed with it and consumed with it that it was kind of distracting. And I said, well, can we bring back Potato Head to just live at the doctor's office? So we said to him, you're going to go to the doctor's office and you're going to get Potato Head. And we wrote him a social story. We showed him a picture. You're going to get Potato Head at the doctor's office. But he lives there. He can't come home with you. He lives there. And we showed him a picture of the doctor holding Potato Head. And he went to the doctor's office, and the first time he just played with Potato Head there, just complete non-contingent reinforcement, no just pairing, counter conditioning, a new association with the doctor's office. The next time we up the ante a little bit more. Okay, if you get on the examining table, you can hold Potato Head. So again, it's not forcing him, it's motivating him with the use of strong reinforcers, right? So then he got on the examining table, and next time he was able to have them look at his ears and check his body. And by the fourth time, he was getting blood tests while holding Potato Head, right?
Mm-hmm.
So it's different than contingent reinforcement in that we weren't saying first do this exposure, then you get it. We were allowing him more of a counter conditioning approach almost. We were allowing him to have it during the exposure itself, but upping the ante a little bit on what we were requiring each time, right?
Oh.
So I think you can motivate children to do it on their own, and then that they feel that sense of control. And
Yep.
then the other thing I just want to emphasize is that, along in the 70s, they did this study on little kids, not kids with autism, with a fear of the dark. And
Mm-hmm.
in one group, they taught the kids to say, they made a recording for the kids that was basically telling them the dark's not scary, right? Because we know that anxiety is the overestimation of threat and the underestimation of your ability to cope with it, right?
Mm-hmm.
So they had these two groups, one basically saying the threat's not that scary, the dark isn't that scary, essentially was what the message boiled down to. On the other group, they made a recording for the kids that was basically like, I'm a big boy, I'm a big girl, I can take care of myself in the dark. That group did much better. And I think it hits the point home that as adults, as parents, as teachers, we always think we have to say, oh, the thing you're afraid of isn't scary. It is scary to them, and telling them it's not scary isn't going to change much, right? Instead, what we want to do is impart that no matter what happens, you can cope with it, right?
Mm-hmm.
That is what really helps kids, as you said, to feel brave, to feel a sense of competence, a confidence that they can handle whatever comes. No matter
Yep.
what happens, I know you can handle it. I believe in you. It feels
Mm-hmm.
uncomfortable to brush your teeth with this, but I know you can handle it. I know you can do it. I believe in
Yep.
you, and have them say that. So really the most important thing, I think, is just teaching them that those coping mantras, and that just facilitating that sense that they can do it, and
Hmm.
leaving the choice and control to them.
Even as adults, is that we want to know that what we
Yeah.
can do. We don't want to be reminded constantly of what we can't do or what
Right.
we should be fearful of. Is that we want to know what can
Right.
we do? What are we able to accomplish?
Right.
But
Right, you're absolutely right. And through all that rescuing that parents are doing, which they're doing well-meaning to, I do it
mhm,
myself sometimes. I fall into that trap. You want to rescue your kids. You want to help them. You want to, if they can't answer a question, you answer it for them. But again, the
mhm,
more you kind of accommodate and rescue them, the more they really, you send that message, oh, you can't do it. I
yeah.
don't believe you can do this. I don't believe you can handle this. When
Hmm.
instead the message you want to be sending is, you can do this. You've got this. I can do hard things. You can do hard things, right?
And I mean, we're so looking at the field that we're in, it's
Yeah.
constantly evolving. I think it's getting
Yeah.
better in so many different regards. And I think that the supports that are out there to be able to be provided to those that are looking for additional skills, or to work with somebody on being able to open up different environments or feel empowered, is that they're getting better as time comes on. You all
Yeah.
worked on developing Spirit, which I think is another one of those gateways for empowering providers and the care community to be a part of things. What's still missing out there? What should we keep pushing ourselves to get better at and to understand more, if you
Oh,
were
that's
to
such a
to
good
put yourself on
question.
the spot?
No, that is such a good question. Wow. I would like parents to think about how to be coping models for their kids. I think a lot of the time, Phil Kendall's done a lot of research on this. Parents often think they have to be what's called mastery models, models of perfection. Like I remember a parent a long time ago I worked with saying, of an anxious kid saying, I was really afraid to go skiing, but I didn't want to let on. I was afraid. I just did it. That would have been a perfect opportunity. So to say, I'm really scared to go skiing and I'm going to do it anyway. The more you can model for your kids what it looks like to face your fears and do hard things. I do that for my kids all the time. I get nervous sometimes going to parties where I don't know a lot of people. So I will say to my kids, like, I'm really nervous to go to this New Year's party who I'm going to talk to, but I know you really want to go. So I'm showing you that I'm being brave and I'm doing this, even though it's hard for me. So I would say model that all the time yourself as a parent. Talk out loud, model how you cope with anxiety and things that are difficult for you. And then the last thing I would say, yeah, instill coping thoughts in your kid, but also try to figure out, I think it makes sense we get frustrated sometimes as parents and we could get overly critical. I think, and I would recommend, trying to avoid being critical or saying, why are you afraid of that? Or getting frustrated, as I know is all too easy, but also to avoid reassurance, of course you won't fail that test. Because again, the reality is we don't know what's going to happen. The
Mhm.
better thing is instilling coping and saying, you studied hard, you haven't failed a test before, so it's probably not too likely will fail the test. But at the end of the day, I don't know what's going to happen. Whatever happens, I know you can cope with it. You know,
Mhm.
that is how in general we want to respond as parents, that we want to respond again, not with excessive reassurance or overly critical, but somewhere in the middle of just facilitating that they can, cope with whatever happens. But that's a drop in the bucket compared.
Mhm.
I think there's so many, we just have such a long way to go in terms of access. Most kids and adults on the spectrum still can't get the mental health care they need. You know, I mean, even at training clinics, it's an uphill battle. I'm working with a clinic at St. John's so that, they can feel more comfortable taking on cases of, of kids with autism who come through there and supervisors. So I think we have so much to go in terms of helping most providers still feel confident, competent treating this population. I think that's one thing. And then I think certainly the other biggest area I think of need, like I said, is the kids who have higher support needs. They have really, really been neglected. And like I said, when I started grad school, there was nothing on basically assessment and treatment of anxiety in anybody. Now there's really quite a lot in um, individuals with lower support needs. There's really quite a lot of evidence at this point showing CBT is effective with that
Mhm.
population. Um, they still can't access it, unfortunately, because not enough people in this country are trained in these evidence-based treatments, like Facing Your Fears by Judy Raven, Audrey Bickley Smith, or like Biaka by Jeff Woods. I mean, most people in the country still are not trained in these evidence-based treatments. So most kids still can't get access to these treatments. That's the biggest problem.
Yep.
So there's that access gap. But even in the research, the kids who are still being ignored, and adults, are those with a co-occurring intellectual disability, who have higher support needs. Those are the kids I'm most interested in, who I'm always trying to work with the most. And Audrey Blakely Smith recently did a pilot study modifying Facing Your Fears for adolescents with intellectual disability. So it is starting, thankfully.
Yeah.
But we still have a long way to go, I think, in terms of that. We have a lot of progress we need to make in terms of helping those kids who it's really often really overlooked or in that population.
Well, once the material is out there, it's a cascading effect, is that as
Yeah.
you learn more questions are asked, we're able to get further research, we're able to get more practitioners, we're able to expand a practice. Where can folks go to start their journey of understanding? Where are the resources to understand spirit and to be involved if that's where somebody
Yeah.
wants to go?
Yeah, that's such a great question. Well, if you go to the Drexel University, I can't even put the link in there. They have they do spirit trainings. I can put the link in there before we part. At the University of Colorado, where Judy Rave and Audrey Blakely Smith are, I know they do Facing Your Fears trainings for providers, for professionals, and I think they might even do virtual groups for people who, are interested in telehealth. Susan White, Carla Mazeski, she's got a lot. Jackie Rogers has wonderful free resources on her website at Newcastle University, that has like a lot of visual supports for autistic adults, but you can use them for kids too, in terms of social stories on helping them tolerate their uncertainty, or sit with uncomfortable feelings. So she has a lot of really wonderful visual resources there, and mindfulness exercises. I can put a lot of those links in there. I'm happy to share any of those links. I'm trying to think what else. Ooh, and Jeff Wood has actually published a lot of his videos. Maya videos, like his treatment was originally Biaka. I think it's, been renamed Maya, MEYA. And they have videos, where they basically demonstrate a lot of those therapy skills.
Or if you have
Yeah.
a gap in the ability to be able to care for different clients that are coming in, it's so important to
Hmm.
reach out, find that information, and share it as time goes on so that we
Yeah.
can
Yeah.
grow as a community. But
Yeah, absolutely. I put the spirit training in there too.
ah,
There's also, I think, some books that are helpful. There's books by Susan White. For adults, there's a book by Valerie Gauss on modifying CBT for adults, on the spectrum. I think Tony Atwood has a good book, on anxiety in this population. My colleagues that are hoping to write a book at some point, not there yet. But those are some of the places you could definitely go to learn more about this.
and that's definitely a start. And the more
Yeah.
that it's talked about, the more that we're having these conversations, I think that the better we're going to become at providing the right care at the right time, in the right modality. And I
Yeah.
think that that's so crucial for how we're trying to be able to help empower and allow people to live the life that they're hoping to be able to live and accomplish things that are important to them. But Dr. Moskowitz, thank you so much for coming on today and sharing your information, your knowledge, and your passion.
Oh, thank you so much. It was so wonderful talking to you. Thank you so much for having me.
Thank you for listening to Autism Weekly. We hope you tune back in next week to learn more about autism in the real world. Autism Weekly is now found on all the major listening apps, including Apple Podcasts, Stitcher, Spotify, Amazon Music, and more. Subscribe to be notified when we post a new podcast. Autism Weekly is produced by ABS Kids. ABS Kids is proud to provide diagnostic assessments and ABA therapy to children with developmental delays like autism spectrum disorder. You can learn more about ABS Kids and the Autism Weekly podcast by visiting abskids.com. Thanks for tuning in. See you again next week.